Hello, my dear students, welcome. We are doing sessions on psychiatry and we are on to a new session now, and it's about drugs of abuse. And that's a very important issue. I would like to remind you, on the modules of psychiatry, when we discussed individual diseases, individual clinical conditions, we tried to cover the pharmacology or the drugs for all these individual diseases there and there itself with each module. And if you want a concise view or overview of all the psychopharmacological drugs, I request you to go to the pharmacology modules of the same website where you can get all the psychopharmacological drugs together for your revision. And I advise you go to it. It's going to be extremely useful to you. Otherwise, when you are doing psychiatry, you will find the discussion of the psychopharmacological drugs at each of those clinical conditions. And now on this module, we only discuss the drugs of abuse. I have a different way of looking at this particular chapter. There are 4 important groups of drugs, which I call as drugs of abuse. And there's also group 5 and 6, which I'll come to later. But if you look at this particular table, it will tell you what is my concept of looking at it. I want to divide it into 4 groups. Number 1, drugs of abuse, which are central nervous system depressant drugs. Number 2, the central nervous system stimulant drugs. Number 3, the drugs which are specially called hallucinogens or psychedelic drugs or mind revealing drugs like LSD and PCP. And the last 4th category I ascribe to a special substance, and that special substance could be none other than marijuana. So that is my way of looking at it. In addition to this, there are some other substances which I am taking up as the group 5 and 6, that's E and F. So A is CNS depressants, B is CNS stimulants, C is hallucinogens, and D is marijuana. So probably we'll be able to cover most of the important drugs of abuse. If you look at this table, under CNS depressants, we have barbiturates, we have benzodiazepines, we have heroin and morphine-like substances which are opioids. In the CNS stimulants, we have nicotine, we can't forget cocaine, we have amphetamine and amphetamine-like medications, and we have caffeine and theophylline, the xanthines. Under hallucinogens, there's LSD and PCP and a special place to discuss marijuana. So, as far as the drugs of abuse are concerned, before going to the actual individual drugs, you need to know about the various schedules of the controlled substances. Schedule 1, as you see on this slide, includes the drugs which have no medical use and there's very high abuse potential. That's heroin, LSD, marijuana, mescaline, PCP, MDMA and flunitrazepam. All this, no medical use and there's high abuse potential. The Schedule 2 includes the drugs which have some medical use but there is high addiction potential, and these include strong opioid agonist, includes cocaine, amphetamine, methylphenidate, and also includes short-acting barbiturates. Going to the next slide, we get the drugs which are in the Schedule 3, and these are the drugs with medical use and there is moderate abuse potential, and these include anabolic steroids which are used by some athletes sometimes and also by the lay public. Then you have codeine in this group. Then the moderate opioid agonists, the strong opioid agonists are under Schedule 2 and the moderate opioid agonists come under Schedule 3. Then you have dronabinol and thiopental. And lastly, under Schedule 4, you have the drugs with medical use and with comparatively low addiction potential. You have other benzodiazepines, then chloral hydrate, meprobamate, weak opioid agonist, and the non-benzodiazepine group of drugs, the Z drugs, that's zolpidem, zaleplon, and zopiclone. So that's about the various schedules 1, 2, 3, 4. Now we come to the group A, the first group. I call it as CNS depressants. If it is heroin or heroin-like drugs, we need to treat this addiction with the help of a long-acting opioid agonist, and that's methadone. You can also think of using L-acetyl-methadol. You can use in addition clonidine to manage this addiction. Plus, instead of methadone, you could think of buprenorphine, and a drug will be useful to decrease the craving. That's called naltrexone, which is a pure opioid antagonist. Going down on the slide, benzodiazepines or barbiturates. The withdrawal is treated with the help of beta blockers like propranolol, as well as you can use clonidine. And for replacement, you need to go for other benzodiazepines, that's estazolam, midazolam, alprazolam or oxazepam could be thought about. Go to the next slide. This is showing you about the CNS depressant drugs, that's morphine, heroin, methadone and the fentanyls, the heroin and opioid-like drugs. The effects of these drugs includes obviously euphoria, analgesia, sedation. They suppress the cough and they lead to chronic constipation and pinpoint pupils. These pinpoint pupils are not observed with meperidine or pethidine, which has got atropine-like effects, and the pupil may be dilated with pethidine. As far as the toxicity is concerned, the overdose is concerned, the severe respiratory depression, and we need to use a pure antagonist, opioid antagonist in the form of naloxone. And the toxicity might include nausea and vomiting in this patient. As far as withdrawal is concerned, the typical withdrawal symptoms with opioids is lacrimation, yawning, sweating and restlessness. This is rapidly followed with centrally originating pain. So there may be severe body pains. You need to remember these drugs are analgesics. So when there is withdrawal, you are likely to get hyperalgesia, and this is why you get muscle cramping. These drugs normally on constant chronic use produce constipation. So when there is withdrawal, you expect diarrhea. So that's the next one which is mentioned. Centrally originating severe pain, that's hyperalgesia, muscle cramps and diarrhea. And the withdrawal is not supposed to be life-threatening. We already saw for this particular group, we need to use methadone, long-acting opioid agonist as replacement therapy. The next slide is showing you the second group, that's the CNS stimulants. And I have abbreviated the CNS stimulants as NICOA, NICOA. NI stands for nicotine, CO stands for cocaine, and A stands for amphetamine. This is one of the ways to remember the three important drugs under the CNS stimulants: NICOA, NI nicotine, CO cocaine, and A amphetamine. Nicotine is used as gum, as transdermal patch, and for managing the addiction, clonidine and bupropion might be useful, and you can use also other antidepressant drugs. Cocaine leads to euphoria and alcohol-like symptoms, and it inhibits the reuptake of dopamine, norepinephrine and 5-hydroxytryptamine. When it inhibits the amine uptake, the cocaine picture looks like a sympathetic drug, and this is why you get dilation of pupil, you get increase in the blood pressure, you get tachycardia, palpitation, etc. You need to manage the addiction with the help of antipsychotic and antidepressant drugs. For example, you can use tricyclic antidepressants. In addition to this, you can use SSRI, selective serotonin reuptake inhibitors, and you can also use benzodiazepines. The last drug on this slide in the CNS stimulants, that's the A out of NICOA, is amphetamine. Amphetamine is an indirectly acting sympathomimetic amine. It releases the neurotransmitter. It's also a weak MAO inhibitor, and it also blocks the reuptake of norepinephrine and dopamine. In addition to amphetamine, the other drugs which are abused are dextroamphetamine, methylamphetamine. The next one is MDA, that's methylene dioxyamphetamine. And the last one mentioned here, a very important drug, MDMA, that's methylene dioxymethamphetamine. If you get toxicities with these drugs, I need to tell you, all these drugs are supposed to be alkalis. And this is why you need to acidify the urine. So there's acidification of urine, acidification of plasma with the help of intravenous ammonium chloride. And for managing the addiction, again, we need to use antipsychotic drugs and antidepressant drugs. So that's about the CNS stimulants, nicotine, cocaine, and amphetamine. Now let's have a look at this table. It's trying to concise whatever we talked about cocaine and amphetamines. The effects of these, due to the norepinephrine, the effects are the cardiovascular effects, cardiovascular stimulation, mydriasis, that's again sympathetic action, CNS stimulation and hyperactivity. Due to the increase in the dopamine, you can get psychotic episodes, hallucinations, and endocrine disturbances. Then due to 5-hydroxytryptamine, you can get behavioral changes and you can get aggression. The toxicity of cocaine, amphetamine manifests in the form of cardiac arrhythmias because it's going to be cardiac stimulant. There can be precipitation of myocardial infarction, precipitation of stroke. There may be renal or hepatic failure if the dose which was taken was very high. The symptoms include psychotic symptoms. The cocaine delirium is a very typical phenomenon with altered level of consciousness. And because serotonin is very high, you could get serotonin syndrome. This patient finally may show convulsions, hyperpyrexia, and death. The withdrawal with cocaine or amphetamine manifests in the form of craving, mental depression, anhedonia is incapacity to obtain pleasure, and very severe anxiety symptoms. And we manage these conditions, the withdrawal, with the antidepressant drugs. We move on to discuss a little bit more on cocaine. Arrhythmias, seizures, and respiratory depression is extremely important, and there could be mood depression, and antidepressants are useful to treat the withdrawal with cocaine. The next slide is about the group C, or the third group, which I mentioned initially as the hallucinogens. They have various different names. You need to remember these names because the question might come with this name. They might be called psychotomimetic agents. They might be called psychedelic drugs, or they are also called mind-revealing agents. And all these agents, that's LSD and phencyclidine, PCP, they increase 5-hydroxytryptamine, dopamine, and norepinephrine. So it becomes easy to remember. It's again sympathetic stimulation. It's again psychosis-like symptoms, and it's again due to the increase in the 5-HT, there may be hyperactivity. So euphoria, a dreamy state, hyperactivity, introspection, and getting new ideas. So after intake of this drug, the patient goes in a dreamy state, patient goes in introspection, patient starts talking and comes up with new ideas. So that's why it's called as mind-revealing or psychedelic agent. The first one is LSD, that's lysergic acid diethylamide. And to manage this addiction, beta blockers in the form of propranolol or a centrally acting alpha agonist like clonidine, which is a sympatholytic agent, is useful. And the next very important drug is diazepam or the other benzodiazepines will be useful. The second agent, very interesting agent, is PCP or phencyclidine, and this typically produces the dreamy state and the combativeness. PCP is an abbreviation. Its full name is phenyl cyclohexylamine phencyclidine, and many times during the day-to-day use we just say phencyclidine or PCP. This is an extremely toxic agent. It can lead to horizontal vertical nystagmus, paranoia, and rhabdomyolysis, and the overdose with PCP can lead to convulsions and death. Easy to remember, the previous group was also producing sympathetic stimulation. I'm saying about cocaine and amphetamine, if you remember. And this group also increases 5-HT, dopamine, norepinephrine. And coincidentally, both the groups, the drugs are alkalis in nature. And this is why for cocaine, amphetamine, also you need to acidify the urine in case of toxicity. And also for LSD and PCP, you need to acidify the urine. So acidification of urine and then diazepam or lorazepam will be useful to treat the seizures. So in short, group B and group C have got many similar characteristics. Cocaine and amphetamine in group B, which are CNS stimulants, and group C is LSD and PCP, which are hallucinogens. The only difference is the special effect of the dreamy state and the mind-revealing nature is different, which is present with LSD and PCP. Otherwise, sympathetic stimulation, hyperactivity, increasing the amines, and the management of toxicity, all is similar between group B and group C. Now we move on. I said we gave a special place to it. That's marijuana, group D. And marijuana is known by various names. It's cannabis, hashish, charas, ganja, bhang, everything is marijuana. It contains tetrahydrocannabinol or THC, and it acts on CB1 and CB2 receptors. These are the cannabinoid receptors, CB1 and CB2 receptors. It is either smoked, or it's used intravenously, or it's used by oral route of administration, and you get three types of effects. Number one is called high, in which the patient keeps on laughing continuously, has euphoria, a false sense of well-being. The patient typically loses the time sense and keeps on doing repetitive acts, and there is depersonalization. Patient might forget and take up some other personality for a short period of time. Next phase is relaxation, in which the patient becomes introspective, is in a dreamy state, keeps on talking and keeps on revealing his mind. The third stage is sedation, where there is increased heart rate gradually. There is conjunctival reddening. Please remember, conjunctival reddening is a very typical feature of marijuana use, and the patient might have delusions and hallucinations. When the patient is in the state of withdrawal after long-term use, the patient might be extremely irritable and the anxiety symptoms are very severe. Marijuana, once again to highlight, produces tachycardia, produces red conjunctiva, and can lead to fall in the blood pressure. That's hypotension. Patient can also have tremors, unsteadiness, and hyperreflexia. The chronic use can lead to some other effects like decreased sexual function. Usually marijuana produces bronchospasm. It could be dangerous in a patient who is already suffering with bronchial asthma. It can precipitate angina. It can lead to orthostatic hypotension, that's postural hypotension, and there's increase in the carboxyhemoglobin. Chronic marijuana use is called as a motivational syndrome, and this person doesn't want to function, doesn't want to perform, doesn't want to go to work, and slowly loses the job. This patient also can suffer from panic states and can suffer from delirium. Marijuana addiction, again two important mainstay of treatment is beta blockers in the form of propranolol and benzodiazepines. So this was all about ABCD, that's the four groups which we discussed: CNS depressants, CNS stimulants, hallucinogens, and the fourth one was marijuana. And as I said, there are two more to be discussed. E and D, or 5 and 6, is isobutyryl nitrite. It's a nitrite. It releases nitric oxide and it is sometimes used as sexual enhancer. And there are some other inhalants which I would like to put with the isobutyryl nitrite. The last group, that is F or number 6, is anabolic steroids, which are used by oral route or intramuscular route of administration. When a patient is using anabolic steroids over a pretty long period of time, you typically see some features in these patients. There is muscle hypertrophy, the skin becomes oily, and there is growth of hair, that's hirsutism, and gynecomastia. And if you examine the patient thoroughly, if this patient is using the drug by injection, obviously you will find needle puncture marks on the body, and this patient might present with edema or might present with jaundice. If you go for blood investigation, surprisingly, these patients have a very high level of hemoglobin and elevated hematocrit. LDL levels are increased and the liver function tests are also abnormal, and the HDL cholesterol is found to be less in these patients. Anabolic steroids have got different compounds, and you need to measure the urine steroid concentration to prove that this particular patient is taking anabolic steroids. So you need specific tests for different compounds. I would advise you to go to the pharmacology modules to know more about anabolic steroids, in which you will find the detailed pharmacology of the anabolic steroids. And few words about caffeine and xanthines. Caffeine and xanthines, they are phosphodiesterase inhibitors. They inhibit the enzyme phosphodiesterase. And I hope you know, when phosphodiesterase is inhibited, there is increase in the cyclic AMP. This activates the protein kinase A, and that leads to activation of the glycogen phosphorylase and the hormone sensitive lipase, and that's going to lead to the breakdown of the glycogen and the triglycerides, and this leads to increase in the performance. Because the glycogen is broken down and the triglycerides are broken down, you get increase in the performance. So I was just trying to explain to you what's the mechanism of action of caffeine and xanthines. Lastly, we go on to see what are the effects of withdrawal for alcohol, because we have not included alcohol on this. It's a special substance, and I again advise you to go to the pharmacology modules to listen to a full presentation on alcohol. With alcohol, you get agitation, anxiety, hyperreflexia, seizures, delusions and hallucinations. And I hope you know it's called delirium tremens. And this is the effect of withdrawal of alcohol. And alcohol withdrawal is again managed with the help of benzodiazepines or valproate and propranolol. That's the beta blocker. For treatment of addiction, we use an aversive conditioning, aversive stimulus in the form of disulfiram, which is going to inhibit the acetaldehyde dehydrogenase enzyme. In addition to this, naltrexone, a pure opioid antagonist, is useful to decrease the sense of craving. Next, as far as opioids are concerned, once again for your revision, the effects of withdrawal include lacrimation, yawning, sweating, restlessness, centrally originating pain, that's hyperalgesia, leading to severe muscle cramps and diarrhea. And we manage opioid addiction with a strong, long-acting opioid agonist in the form of methadone, and you can also use clonidine to manage the opiate addiction. So we went through various drugs, and I tried to put them in a different way from a different concept as CNS depressants, CNS stimulants, hallucinogens, and marijuana as a special substance. And lastly, we discussed about a nitrite, and we discussed anabolic steroids, and I just made a referral to alcohol with an advice to you to go to the psychopharmacology modules on the pharmacology sessions of this website, and also to go to the chapter of alcohol on this website. And this particular module is going to be useful to you. I wish you good luck for your future endeavor, and thanks for listening. Bye.